Thank you all for joining me today for the next installment of our kidney cancer conversations. My name is Scott Nicholson, and I'm very excited to have Dr. Murphy with us from the Moffitt Cancer Center. His role is in hospice and palliative medicine, and so he's here today to talk to us about supporting patients and families in the role of palliative care. Thank you, Dr. Murphy. Welcome.
Thanks, Scott. Thanks so much for having me and for that nice introduction. Really a pleasure to be here with all of you today. And as Scott mentioned, I'm a palliative care physician here at Moffitt Cancer Center in Tampa, Florida. And I wanted to spend just a little bit of time this afternoon talking about what it is that I do for folks, what I do for patients, many of whom are battling kidney cancer, and just to try to maybe dispel some myths, maybe some preconceptions about what palliative care is and what it's not. So I have some slides here that I'm going to start sharing.
Yep, we can see you now, Dr. Murphy. And also anyone, we will be having a Q&A session at the end of the talk today. So if you do have questions throughout the presentation, go ahead and type those into the chat box, and I'll make sure that your questions get answered at the end. Go ahead, take us away, Dr. Murphy.
Great, thank you. So the title of the talk is Supporting Patients and Families, the Role of Palliative Care. And I don't have anything to disclose related to the content I'm going to present today. Topics that we're going to consider. This is designed to be a very broad approach to what it is that we do in palliative care, what we do in our field to help patients and families. So I'm going to define really what our field is all about, what we do, what you might expect from a visit with a palliative care physician. We'll talk about the role of the interdisciplinary team in our field, because as we'll talk about, this is much broader than simply the patient-physician relationship. There are numerous people involved in the interdisciplinary team, all of whom play an important role in helping patients and families. And we'll talk about who those folks are and what they might be able to provide. So many patients are referred to a palliative care doctor, supportive care doctor. We'll talk about all kinds of different names for our field. But so many folks are referred, particularly for assistance with pain management. And I think it's, a lot of people have different concerns about various medications that we might recommend to help folks with cancer-related pain. And so I wanted to provide a 30,000-foot view, if you will, of pain management. And as Scott mentioned, we're taking questions. So if you have questions specific to that, we're happy to address them. We're going to leave ample time at the end of the presentation for that question and answer session. So please do type your questions in the chat. We'd love to hear them. So again, just starting off very broadly, what is palliative care? Some people on the meeting today may already have experience with meeting with a palliative care physician and palliative care team. Others might not. But I wanted to define exactly who we are. And we really are the field of many names. So you may hear palliative care referred to by any number of these names. And you see it's more or less a hodgepodge of palliative and supportive. So these are all different terms that you might encounter when somebody talks about our field. The last bullet point there is alluding to the actual name of our field. So I'm board certified in the field of hospice and palliative medicine. That's the actual name of the specialty. And though hospice is in the name of the specialty and part of what we do, we'll talk a little bit about hospice later in the talk. But what we do is far more broad than simply hospice. That's a small part, in fact, of what we do. So these names may be, unfortunately, confusing for patients and families. Who am I getting sent to? Many times When I meet with patients, the first question I ask is, what's your impression of why you're sent to me today? And fortunately, the vast majority of times people already have a sense why they're being sent, whether it's for pain management or maybe the management of a different symptom. But it can be confusing, right? Who is the palliative care team and why do I need to see them? Rest assured, regardless of what the service may be called at a particular institution, the services that are going to be offered by the team are similar. So here at Moffitt, we are the Department of Supportive Care Medicine, which encompasses palliative medicine, behavioral medicine, and integrative medicine. But at the end of the day, again, regardless of what it's called, you can expect a lot of the things that I'm going to be talking about are going to be offered, and things that you're going to be doing with your palliative care doctor. So if you look at it from a kind of broad definition, palliative care really is patient and family-centered care, right? And that informs the name of the talk today, supporting patients and families. And working to optimize quality of life by addressing physical, intellectual, emotional, social, and spiritual needs of patients and families for folks with serious illnesses like cancer. Of course, today we're talking about kind of more specifically people battling kidney cancer, but palliative care physicians can certainly be involved in the care of folks without cancer, but with other serious illnesses. I mentioned this earlier, but care is provided by an interdisciplinary team. Now, who's part of that team? Well, there's a lot of people involved. Certainly, you've got the primary medical provider, whether that's a physician like myself, a nurse practitioner, a physician assistant, but you've got a slew of other folks, nurses, social workers, chaplains, child life specialists are sometimes people who can be part of that interdisciplinary team to specifically address the needs of children, whether those are children suffering from serious illness themselves or family members, young children, children who are family members of folks who are fighting serious illness, and knowing, some methods of interacting with children, sharing news with children. And then you've got integrative medicine, which, for instance, here at Moffitt, we offer yoga, massage therapy. We offer a lot of these services. So these are other services that can certainly play a helpful role in managing troubling symptoms and improving quality of life. And the interdisciplinary team meets frequently. High-level communication is part of palliative care as well. And I think, if anything else, having palliative care, palliative medicine involved allows for a high level of communication amongst different specialists. So I mentioned a little bit already, and I'm going to get more into this in the second half of the talk, but pain and symptom control, advanced expert pain and symptom control is certainly at the heart of what I do as a palliative care physician. The majority of folks that are referred to me are referred for help with pain and symptoms. We also play a strong role in helping patients and families understand their illness, and also, importantly, helping the healthcare team understand how that illness is affecting patients and families. A lot of people say come to their oncologist appointment, they're talking about what's the, where are we now with regard to the state of my cancer? What's the next step? What's the recommendation for the next step in care? And so that can oftentimes, I think, feel like a one-way road of communication where there's a lot of information coming at the person and their family in terms of next steps. And I'd like to think that what we offer as well is helping the healthcare team understand the needs of patients and families. I take a lot of time when I meet a patient for the first time. You're going to expect to sit down with me for 45 minutes to an hour, just talking about how are things going? How is this, situation? How is this illness affecting you personally and your family on a day-to-day basis? What are things like in the home? And that's very different than what we might see and recognize in a 15 to 30 minute office visit, right? So it's an opportunity really for everybody to understand where are we? What's going on? How can we best support this patient and family? We help people delineate goals. What are we hoping for? What are we hoping for from this treatment? Helping them to understand the benefits and burdens of treatments. Very few medical treatments are without any type of side effect. And so everybody has a very individualized line in terms of managing, expectations and hopefully receiving benefits, but also limiting the burdens of those treatments. And what are the things that we can do? And really that comes down to what's called shared decision-making. And that is when we take our time, we sit down and we talk about your goals, your values. How does all this fit into your life, right? And frequent touch points and seeing how that might change over time is really important. It's really valuable to recognize, well, is it possible that we've started going down a path that's really not conducive to me as a person and my family? Are we starting to see more burdens than benefits? One example, we help people to start thinking about, get pen to paper, talking about things like advanced directives, which is basically an overarching term for documents that are addressing that person's wishes and desires for care that they would receive. If, for instance, they lost the ability to communicate that to somebody, it's an opportunity to identify who is the person who is the go-to person in that patient's life to help make decisions on their behalf if they were not able to. And part of that is talking about code status, which really means the use of things like life support, things like breathing machines, doing advanced things like CPR and those types of things. And some people come to visits with me knowing, yes, I would want to try all those things, or no, I absolutely would not want to do those things. Most people, I think, fall somewhere in the middle. And it's just an opportunity for us to sit down and talk about it so that if it did happen, that we are doing exactly what that person would want. And I mentioned this earlier, the coordination of care. You've got really high quality, high level communication between multiple team members. I'm constantly in communication with my patients, oncologists, radiation oncologists, other subspecialists here at Moffitt. And I think that that's really valuable. I tell folks that I want them to utilize me for a number of things. If I make recommendations for, say, pain management, I'd like to hear back from that person, right? Let's not wait until the next visit, but give me a call or send me a message. If you're doing wonderfully, that's wonderful, that's fabulous. That's exactly what we're hoping for. If the recommendations are not being as helpful or somebody's having side effects, I really want to know about it because we're going to sit down again, we're going to talk about it and change the plan a little bit. I also tell people, if you're not sure who to go to and something doesn't make sense, feel free to reach out to me, right? I think of me as somebody who can get that information to the right person, and we're going to be able to help patient and family get the information that they're looking for, because this can be overwhelming, having so much information coming from multiple sources. I tell my patients, you're honestly 10, 15% of whatever I say, if you hold on to it, that's probably typical. That's why I think there's such value in having, thoughtful questions, letting the patient know, send me a message, my door is always open. And that is a central tenet of what we do in our field. I want to just switch gears a little bit to talk briefly about hospice, which I mentioned at the top of the talk. So palliative care really does not equal hospice. And I think a lot of people hear the words palliative care, they might assume that what the other person, the person speaking to them is talking about is hospice, or maybe they think they're being told that they're dying. I can tell you that in the vast majority of situations, this is not the case. I will tell you, just in my personal experience in my practice, most people are told, I'd like to refer you to palliative care or supportive care. It really is to assist with some of the other things that I mentioned: pain and symptom management, shared decision-making, delineating what our goals are moving forward, and really establishing a safety net. I like to think of our field also as a safety net again, that pick up the phone, you're not sure what to do, you're not sure who to call, we can be there to assist patients and families. So again, in the vast majority of situations, that's not the case if somebody is sent to me that they're actively dying or that their oncologist is saying, I want to refer you to hospice. But I will say that as the name of our specialty implies, again, the name of our specialty is hospice and palliative medicine, board certified palliative care physicians like myself do have that extensive specialized training, and we are considered the experts at caring for people receiving hospice care. I don't practice hospice personally. I see patients here in the office and practice outpatient palliative care. I see folks when they're admitted to the hospital, and I'm a consultant and offer consultative palliative care. But there are certainly many physicians who are palliative care doctors who practice hospice, and that's their full-time job. So what is hospice? Well, it's a model for quality, compassionate care for people facing serious life-limiting illnesses. And I describe hospice as aggressive. It really is some of the most aggressive medical care that one can receive. And it involves managing distressing symptoms, typically in the home, but sometimes that care can also be administered in a freestanding hospice facility. We won't get into the nitty-gritty of that, but it really is a shift of focus, avoiding those burdensome disease-specific treatments if they have become more burdensome than helpful, and focusing on those treatments that are more directed at improving quality of life, aggressive symptom management, improving function, and for most people being in the home setting. That's where most people strongly prefer to be. Care is still provided by that same interdisciplinary team with that frequent high-level communication to discuss the care of patients and families. And there is significant emotional and spiritual support that's tailored to the patients and families' needs, which is really nice. And this is available to all persons, and it's covered under Medicare, Medicaid, and private insurance. This is just a graph outlining maybe a sample of somebody with chronic serious illness. And you can see here in the largest box, the kind of half white and half blue box, you see that curative care, right? And that might be the care, provided by, say, an oncologist, right? With a goal of curing that person's cancer. And then the blue, you see palliative care, which is, again, what I do, and that side of things directed at pain and symptom management and supporting patients and families with shared decision-making. And you can see here on the left-hand side, when a person, say, is first diagnosed, their oncologist is doing pretty much everything, right? The oncologist, there's that initial consultation, talking about the plan of care, explaining this is, what to expect from my perspective. And that person might get on to some cancer-directed treatment. And with time, there's going to be waxing and waning responses for a lot of folks. And some people will have cure, some people will have remission of their disease, in which case this graph looks differently and more or less might stop at this point. And for folks who have progression of disease, despite those multiple lines of treatment, you may see that palliative care physician becomes more and more involved in the care of that patient. If they start to have worsening symptoms, if somebody starts to have worsening pain, worsening nausea, worsening constipation, whatever it might be, the palliative care doctor may be playing more and more of a role in that person's care. If that person, whether we're talking about cancer or any other illness, unfortunately, the treatments are not being helpful to that person, and there's either a decision to stop those disease-directed treatments, or there's simply not an ability to give additional disease-directed treatments. That is when somebody would start to qualify for hospice, and we might start talking about hospice as the best means of taking care of that person. And typically that entails recognizing that that person likely has 6 months or less to live. That's part of the criteria for enrollment. However, there are many people who outlive that 6-month mark, and that involves, recertifying that person for hospice services. And then, if that individual dies, if that person passes away, part of that role of hospice is offering bereavement services, offering support to that person's family for a bit over a year after that person passes away. So I think that can be very valuable for patients and families. And again, this is a time course. It's not necessarily everybody. This is simply one example of how we might think about that. So I want to spend just a few minutes on pain management, because I think that this is, again, such a large part of what we do. And I think, that this may be informing some of the questions that are going to come through. So again, if you have questions about any of this, I'm happy to share my thoughts. Please go ahead and share those questions in the chat. So again, thinking about folks specifically with kidney cancer, a referral to palliative care may be recommended for assistance with pain. I take care of a lot of folks with renal cell cancers. In my practice, this actually accounts for the majority of new consultations, the majority of new patient visits of folks that come to see me and then subsequently follow with me. We work together, making thoughtful changes to, say, medications to manage their pain. This is really important. I think it allows the oncologist to really focus in on those cancer-directed treatments, recommendations directed at chemotherapy, immunotherapy, whatever the case may be. And it really allows myself or one of my colleagues, for instance, to focus in on pain and symptoms and really dedicate a significant amount of time to that, which in the next slide, I'll demonstrate why I think that's really important. And just as a jumping off point, we're talking about things like nociceptive pain, which is pain, as an example, from tumor itself that's pushing on something that's not supposed to be pushing on, and that can manifest in pain. Got neuropathic pain, that's nerve type pain. That can be due to the tumor itself. It can be due to side effects of chemotherapy or radiation, as another example. And you see right there, we definitely help folks manage some of those that can be bad side effects due to chemotherapy, radiation, et cetera, those cancer-directed treatments. And I always tell folks I take care of, everything is a trial. And I really believe that, in the sense that if somebody comes to see me, we're going to sit down together, try to understand what's going on when we're talking about pain, what's working, what's not working, maybe what's been tried in the past, and come to a consensus. Maybe I'll make a recommendation, or even 2 or even 3 different recommendations, all of which might be reasonable. And we sit down and we talk through those different options and figure out which one might make the most sense and fit into that person's life. And then I tell folks, well, we're going to find out in a week. We're going to call you in a week and find out how you're doing. I'm going to see you back in a few short weeks from now. And if you're doing great, wonderful. I couldn't be happier. That's exactly what we're aiming for. If we're having side effects or you're not feeling any better, I need to know about it. And we're going to sit down again. We're going to pivot the plan and start a new trial. So everything really is a trial. This is just, you don't need to memorize this or commit this to memory or anything like that. Some of you may recognize some of these words, these various pain medications, maybe some personal experience or secondhand experience with these. But this is a simple version of the World Health Organization's pain ladder, which was released in the late 90s and was intended to serve as a general guide to help clinicians, help folks manage pain in the setting of cancer. And all I want you to take from this is, you see here in step 1, we're talking about acetaminophen, which is Tylenol, and these adjuvants, which are some other medications that I'll talk about. We might try those things first, and then if that person is still having uncontrolled pain, we'll go up to step 2. We might try one of these weaker opioids that you see listed here, along with the things from step 1, right? This is stepwise, so we're adding step 1 onto something from step 2. And then up to step 3 for people who have refractory and severe pain, to steps 1 and 2, we might use one of these stronger opioid type pain medications as well as those other options from step 1 and 2. So again, this is just trying to demonstrate a little bit of that very thoughtful stepwise approach that we take in our field, knowing that there are many concerns, both from patients and families and clinicians about some of these medications. So rating pain. I imagine many people on the call have been asked to rate your pain on a scale from 0 to 10, 10 being the worst. And that's challenging. Pain is part of the human experience. It's universal to all of us. But despite this, it can be immensely challenging to explain pain to their doctor, right? It can be a very difficult thing to express in words how you're feeling. And those numeric rating scales, they can be helpful to trend over time, meaning I meet somebody and they tell me they're an 8 out of 10, and I recommend we start them on a medication, and I see them back 4 weeks later and they tell me their pain is now a 5, I can feel like likely we're making a step forward, right? We're making some progress. But remember, my 8 out of 10 might not be yours. Most people tell me that 3s and 4s and 5s are numbers that allow pain to, yes, be on their mind, but it's in the back of their mind. They're able to focus on the task at hand. They're able to go about their activities during the day. Those same people who tell me 8s and 9s and 10s are not conducive to good quality of life. Pain is on your mind and it's in the front of your mind. It's all you can think of. And it affects those other domains. And what I mean by that is people who have uncontrolled pain are probably also not sleeping well because of uncontrolled pain. And if you're not sleeping well and you're in pain, then your mood is probably not going to be very good. And if those things are all happening, you're probably going to be more fatigued during the day. And if you're fatigued, you're not walking around and moving around, and you could get weaker and your appetite might be poor. So you see, I talk about this cycle that we try to break, and just pain being one example. But if pain is driving that cycle and we break it, then these other qualities of life and these other domains of life can improve substantially. You're sleeping at night, so you're not tired during the day, so you actually feel like eating. So I tell folks all of these things are related. So how pain impacts functional status is most powerful. If I meet somebody for the first time and they say they're not really walking around because walking around gives them, terrible pain. And then I say, okay, we need to try to treat this a little bit more aggressively and get you feeling better. And then they come back 4 or 6 weeks later and they say, well, I'm taking the medication. I'm able to walk around the house now. I'm able to get back and forth to the bathroom. I'm able to go to the kitchen because the pain is more tolerable. So to me, that's the most powerful thing. Has this person's function improved? And how does that fit in with quality of life? I just put here for you guys to see, you got the numeric pain rating scale. You also have down here the Wong-Baker Faces pain rating scale, which maybe you've seen. We tend to use that more in children or in folks who just have a difficult time, using that numeric scale. And so using that face, which correlates to a number, can be helpful for some people. So if you've ever seen that before. I want to just talk briefly about commonly recommended pain medications that you might see recommended by a palliative care physician. And this, again, is not to memorize, it's just to give you examples. And if you heard of these medications, again, we can expand on it in the Q&A session. For folks with mild pain, again, thinking about that step 1 of the ladder I showed, you're talking about things like acetaminophen, which is Tylenol. You're talking about the non-steroidal anti-inflammatory drugs, AKA the NSAIDs. Those are things like ibuprofen and naproxen, and you see the trade names there. And you also have medications like gabapentin, right? Also called Neurontin and pregabalin, which is Lyrica. These are medications that we might use for nerve type pain that you might experience for that. You might be it might be recommended to start that for that burning or tingling or electric type pain, which feels very different in many ways from other types of pain. Then you've got moderate pain. This is where we start getting into some of those opioid type pain medications, but these are what are by and large considered the weaker opioid type pain medications. Tramadol, hydrocodone, oxycodone, morphine. A lot of these words can seem scary, right? People, I say the word morphine to somebody, they might think, oh my goodness, right? morphine has been around for 60 years. It's the prototypical opioid pain medication. And what I want you to know about these is most of these medicines, when we take a pill and our bodies break them down, the chemical, the end result, the end molecule, they look somewhat similar to the receptors in our body. And so sometimes, I'll just tell you, I tell people all the time, we're all built differently. So I might try somebody, I might recommend oxycodone, let's try that. They might get really constipated with it, and it might not be that helpful for pain, in which case we say, let's stop it. We're going to rotate to morphine. We're going to try low dose morphine, see if that is more agreeable with your body. And sometimes it is about that gentle trial of different medications to see what works best. And importantly, some of these medications are bundled with Tylenol. They're bundled with acetaminophen, things like Percocet, Norco, and Vicodin. That's important because you don't want to be taking additional Tylenol alongside that. It's very easy to start taking too much Tylenol in a day. Depending on who you ask, somebody might recommend 3,000 milligrams of Tylenol a day. Some folks might recommend 4,000 milligrams a day. But it's very easy if you're taking, say, Percocet as well as extra strength Tylenol to go over that daily limit. So it's important that your doctors know which medications you're taking. And then finally, for that severe pain that might be refractory, that might not be responsive to these other medications, we might recommend stronger opioid pain medications like hydromorphone, which is dilaudid, if you've ever heard of that, fentanyl, which comes in a patch form, and methadone, which I think a lot of people hear the word methadone and they may have, they may understand that that's utilized for some folks struggling with opioid use disorder, with opioid addiction. However, in our field, it's one of the medications we use as advanced, again, expert clinicians to manage pain because it is an opioid, just like some of the other medicines I recommended, or that I mentioned rather. And we may also make a referral to an interventional pain specialist. Those are our colleagues who can do procedures like nerve blocks, Botox injections, steroid injection, things like that to help with pain, in addition to some of the medications that I'm talking about. So again, talking a bit about opioids, which are, again, a medication class that is often at the center of helping folks with cancer-related pain specifically. There are short-acting versions. These are used for breakthrough pain. After you swallow a pill of a short-acting opioid, you get peak effect of that medicine about 45 to 60 minutes after you take the pill. The effects of the medicine usually last for around 4 hours. For some people, it may last a little bit longer. For other people, it may last a little bit shorter. Again, I tell people all the time, we are all built differently. Sometimes people can experience end of dose failure, which is exactly what it sounds like. They take a medication, maybe it lasts only 2 hours, and then they're in bad pain for another 2 hours, waiting until they can take that next dose. Oftentimes, we will switch that person to a different short-acting medicine, and that solves the problem. Sometimes we need to start a long-acting medicine. Now, this is designed to keep a steady amount of pain medicine in your body, in your system, 24 hours a day, even during the sleep hours. So there's always something, at a low dose in your body, even while you're asleep. I have a lot of people who wake up in the middle of the night, multiple times a night, because of severe pain, and they have to take a pain pill. Again, often recognizing how important a good night's sleep is and how that affects well-being, I'll often recommend a low dose of a long-acting medicine so that that person can hopefully sleep through the night without waking up to have to take medication. These long-acting opioids are usually given 1 to 3 times a day, depending on the medication that we're choosing. Importantly, you should never crush or cut long-acting pain medications unless your physician says that it is okay. That's because some of these products are designed to be, again, slow release. And if you crush them, it removes that slow release function and you may absorb all the medication at the same time if you swallow a crushed pill. So I always tell people, don't cut it or crush it unless I tell you that that's okay, because there are a few in which you can do that. But you shouldn't do it unless somebody gives you the go ahead to do so. And then finally, the patch patches are options for some people as well. And if you have questions about patches, I'm happy to answer those in the Q&A. Finally, I just want to put up a slide to talk about the other symptoms that are managed by palliative care physicians. I wanted to focus a bit more on pain management because I think it's a common thing that folks are referred to me for, and it's probably something that a lot of people on the call today might have questions about. But this is just an example of many other symptoms that I manage day in, day out for people. And I'm not going to read through all these, but if you or a loved one are experiencing any of these, and whatever you're doing, whatever somebody's maybe recommending for you is not being helpful, consider the ability to see a palliative care doctor. These are things that myself and my colleagues, again, commonly manage, commonly are able to help people with. And so I just wanted to provide that list just so you can have to know, might it be a good idea to get referred over to a palliative care doctor to assist me with any of these. And so with that, I'm gonna end. Thank you again for having me here to speak with all of you. And Scott, I guess I'll turn it over to you to enlighten us with any questions that are coming through the chat.
Yes, thank you so much for your talk, Doctor. I learned a lot, and we did have a question from Kevin. And if anyone else has questions, feel free to type them into the chat box. We'll make sure that we get your questions answered before we wrap up today. So Kevin asks, Dr. Murphy, could you speak to the potential for palliative and naturopathic processes that can be used prior to and during systemic therapy to minimize ensuing pain and/or side effects?
That's a great question. That's a great question. I will say that in terms of before and even during treatments, a lot of people come to me and they say, maybe they're getting an infusion, maybe they're getting a 3-day continuous infusion every other week, just as an example, for their cancer. And they say, I really feel awful. I feel really bad while I'm connected to that infusion and for a day or two after me. And what can I do to try to mitigate that, to try to improve that? And what I tell people is, even though it's that maybe small period of time, relatively small period of time, that you're experiencing a lot of symptom burden, that accounts for an actual very small percentage of the 24 hours a day that you live your life. And so what I'm getting to is the best things that one can do are to optimize nutrition and function and management of symptoms outside of that time, right? If we know that the chemotherapy or whatever treatment is really being burdensome during that time frame in terms of symptoms, well, let's take advantage of the time that we're off treatment, that we're not actively getting it, to be moving around as much as possible, light exercise, doing whatever we can to optimize sleep and nutrition. And the same thing goes for prior to, say, diagnosis or prior to starting treatment. I have many folks who come to me and they have really taken care of themselves. They've been in the gym, they've been eating healthy, they've been doing, they don't smoke, they don't drink, and they've taken care of themselves. And they get treatment and they can tolerate it well. Conversely, I have people who haven't taken the best care of themselves, right? Maybe they're a heavy smoker, they don't eat a healthy diet, they sit on the couch and don't move around. I have a lot of folks like that who don't tolerate those cancer-directed treatments as well because their physical fitness hasn't been, we'll say, ideal. Now that's a little bit of a stereotype, so to speak, that not everybody's going to fit in one camp or the other. But I think to best answer your question, the best thing I can say is to try to optimize nutrition and functional status, meaning I want people upright, walking around, moving around whenever possible. I don't like when people are spending all day in bed or a chair. To me, that's very concerning. I like people who are able, I want people to try to do their best to walk around. I hope that answered the question.
Mm-hmm. And then Deborah asks, what do you prescribe for medium to high PSIN for patients highly sensitive to all those that you mentioned. And that may be a typo, for medium to high pain,
Yeah, it seems like that.
for patients highly sensitive to all those that you mentioned, currently can only handle Tylenol and gabapentin 100 milligrams, which helps a little.
Sure. Well, I would say that depends on what that means in being highly sensitive, right? There are people that highly sensitive means they take a low dose, a starting dose of, say, an opioid pain medication, and they get very sleepy. They get very lethargic. Could be that people get itching. They start taking medication, they get very itchy. Or maybe they take it and they start having bad nausea and vomiting. So it really depends. In the latter case, nausea and vomiting, that's usually self-limited. So if people start on an opioid and they start feeling sick to their stomach, that usually goes away in an order of a couple of days. And we tell that person to take nausea medication alongside it, and let's give it a couple of days and see if that symptom goes away. If it doesn't, we transition, we switch, we rotate to a different medication. The same thing goes for sleepiness, lethargy. If taking the lowest possible dose of, say, morphine makes you very sleepy, I would recommend likely switching to something like low dose oxycodone, even half of a tablet, to see what is the dose that can hopefully provide a little bit of pain relief while limiting that side effect. And what I do in my office, I use my hands a lot to explain to people is all of our receptors, let's say the receptors in our body, which are called mu receptors, MU, let's say they look like this, and I'm giving somebody morphine and it's making them very sleepy. It's possible that morphine looks like this and it's not really binding so well. And by not binding so well, it's causing some bad side effects like being sleepy, and it's not helping with pain. I switch that person to, say, oxycodone, which maybe for their receptors looks like this. All of a sudden, we've got a good lock and key fit. And that's a situation that provides better pain relief and limits those side effects. I'll say one more thing about side effects and sensitivities to medicines. Not all side effects or sensitivities are bad. I think it's very common for all of us to hear the word side effects and think that has to have a negative connotation, that has to be a bad side effect. There are plenty of medications that I commonly recommend to people that I might use for pain or I might use for nausea that can be a little sedating. For instance, the gabapentin that person mentioned can be sedating for many people. I like to harness side effects. How can we give this person that medication maybe near bedtime? And if it makes them a little bit sedated, a little bit sleepy, all of a sudden we're harnessing that side effect, which maybe would be perceived as bad. It would be if during the day that person was asleep all day because of the medicine, but all of a sudden we tweak it, we change it so that it's dosed later in the day, and all of a sudden that person is getting benefit from the medicine and also sleeping better. So I just want to make that point that not all side effects need to be bad, but you need to sit down and talk about what you're experiencing to develop a plan, maybe to harness that side effect. So I hope that helps.
Thank you. And Nancy has a question that you may have answered a lot of this with your last comment, but she says, do you recommend medical marijuana for side effects? And my particular side effects are sore throat and burning mouth syndrome.
Yeah, I mean, so medical cannabis is definitely a hot topic that a lot of people are curious about. I have many patients who share with me that they're using cannabis products to try to help with various symptoms. I can tell you that before I joined Moffitt, I trained and worked in Pennsylvania and Philadelphia. And in that practice, we had many people who were utilizing medical cannabis to try to help with various symptoms. And my thoughts on it are this. Number one, please make sure that I'm aware of it and that your oncologist and your team is aware that you're using that, because cannabis, I treat as a medication as it is. It can interact with other medicines. So it's just immensely important that everybody knows that you're using that. I will tell you that cannabis, the two primary molecules that work in our bodies on the endocannabinoid system are THC and CBD. And without getting too much into the weeds about it, you're going to find different ratios of those two components of cannabis, depending on what you're using, whether it's a vaporizer pen, an edible, a tincture oil, a patch, a roll-on, whatever it might be, we tend to think that THC can be helpful for appetite stimulation. CBD is more so thought to be helpful with nerve type pain, burning type pain. That being said, cannabis is still a Schedule I drug as far as the DEA is concerned. Of course, various states have state laws that allow for its use, Florida being one of them. That being said as well, it's a trial. It's impossible for me to tell somebody that I think it's going, that it will be helpful for symptom X, Y, or Z. I'd say as long as your doctors are comfortable saying it's okay for you to use it, and you want to try it, that's something that you can do. The evidence for cannabis for these various uses is immensely weak. A big part of that is because it's still a Schedule I drug and it makes it very difficult to research. But at the same time, I tell people, if in Florida, state law stipulates that it's legal to use this for certain indications, as long as your doctors know and you're using it safely, not using it for the first time and getting behind the wheel or climbing a ladder, use it safely, see how it affects you and your body, just like you would with any other medication, and then report back to me. Let me know if you feel like it's being helpful. If it is, that's great. If it's not being helpful, well, my usual recommendation is to treat it just like any other medication. If it's not being helpful, let's stop it.
Thank you, Doctor. Julia had a question. Dr. Murphy, my husband has stage 4 renal cell carcinoma and is currently taking Cabometyx and Opdivo infusions. When he gets a CT scan with contrast on his chest, abdomen, and pelvis, he gets very sick from the contrast. One time he ended up in the ER from the sickness. Is this something that I should talk to palliative care about or just his oncologist? In other words, I think he needs IV hydration before and after the CT scan. So who would I talk to about this?
That's a great question. I would definitely say his oncologist would be an excellent first person to contact, especially since that physician is the one, ordering these scans in all likelihood. We know that people can have sensitivity to contrast dye, to iodinated contrast dye. That's the dye that we use for CT scans. And some people get a little bit of fluid. Some people might even require a little bit of steroid to help them better tolerate, to pre-treat them to better tolerate that, that contrast. Without knowing the specifics of the situation, it's hard to ascertain if that's what we would consider a true allergy. But that being said, if it's something that's happened repeatedly, with each CT scan with contrast, it sounds like that's making him really uncomfortable. And it sounds like it's distressing to him and to you. So I would absolutely say you should discuss with his oncologist and see if there's anything else that he or she would recommend in terms of pre-treatment prior to receiving that contrast.
And Sean asks, how do you handle patients who live far from your facility? Should we expect a palliative doctor to work with a local team?
That's a great question. I will tell you that here at Moffitt in our department, our current policy is that we are part of that care team for folks who are actively either receiving treatment here at Moffitt or following with a Moffitt oncologist for ongoing recommendations. That being said, I have people who travel from all over the place, from Vero Beach, from Miami, from Alabama, the Panhandle. I have a few patients who are a bit seasonal, somebody who flies down to see me from Boston, somebody who flies down to see me from Minnesota. So that being said, we are happy to evaluate patients and work with patients who are a bit away from us. The caveat there is that given the COVID-19 pandemic, we were previously allowed the ability to do a lot of telehealth services. And part of that was the ability to prescribe controlled substances like opioids, as an example, to folks without that in-person evaluation. As of July 1st, that law in Florida changed, those rules changed. So we're no longer able to do telehealth with folks if it involves us writing prescriptions for controlled substances. However, I do have people who travel to see me. I try to accommodate their schedule and say, I only want you to come and see me if you're already coming here to see your oncologist or your radiation oncologist. Let's bundle the visits, and I do whatever I can to accommodate that. And that being said, there are lots of local palliative care physicians all over the place, some affiliated with hospitals, some in the community. There's a resource that I'm just going to, if you Google CAPSI, this is a national organization, part of which its mission is to connect patients and families with palliative care clinicians. So if you were to look into CAPSI, oh, I'm sorry, I'm going to just put this in the general chat. You would be able to find a list of local palliative care doctors that you would be able to follow with. I think a local team is always really valuable, just the ability for a rapid assessment if needed. But again, I take care of folks from all over. So if you're, if somebody is being treated here at Moffitt and wants to see me or one of my colleagues here, we would welcome the opportunity to help take care of you.
All right. And Deborah says, thank you, Dr. Murphy. I wish you were my doctor here in Massachusetts.
That's nice, Deborah. Thank you for that. I'm from Pennsylvania, and I've been to Massachusetts. I've been to Boston. I know some folks up there in palliative care. It's a small, tight-knit community of palliative care physicians. There's less than 10,000 board-certified palliative care doctors in the country. And so everybody knows everybody. But thank you for that, Deborah.
And what we got one last question. It's a follow-up. Dr. Murphy, speaking of cannabis or CBD with no THC, is there any known conflict of it with levothyroxine, thyroid meds, or prednisone for hypothyroidism and adrenal insufficiency?
I'll tell you, I don't know the answer to that question offhand. What I can tell you is we know that it does interact with certain medications. I'll give you an example. Methadone, which I mentioned earlier, is a strong opioid. We know that it can interact with methadone. I am actually, and I tell people this at the risk of sounding unscientific, and I literally say that. I don't want you to think this is unscientific, because when I meet with people, I say, I've already reviewed your chart, I've looked at your imaging, I've looked at the notes, I've done all the doctor stuff. Now we can just sit down and have a conversation and talk about how you're feeling and how you're doing. That being said, I also tell people anything can interact with anything, in my opinion, because I've seen it. I've seen things that you wouldn't expect. So at the end of the day, when it comes to cannabis, just since that's your question, it's immensely important that everybody involved in your care understands that you're thinking about using that, you're thinking about trying that, and if you did, does that have any ramifications, any interactions with any of the other medications? And importantly, if somebody starts using cannabis or a different medication, of course, we're going to have ongoing blood work, ongoing monitoring. And if we see something that is surprising, we see something like the thyroid levels are off all of a sudden, well, that might lead us to think that maybe there's something going on, some interaction. So I would just say, again, make sure everybody's aware and listen to your body, listen to, how you're feeling. I tell people, you know your body far better than I ever could. So that being said, that's really valuable. And just keep talking to your doctors so that everybody can be aware what's going on.
Do we have one more time for one more question?
We sure do. Yeah, we have time. Yep.
Okay, great. Donna asked, what is the oncologist's role? My husband has been seeing an oncologist since August 2020, and he's never once mentioned palliative care. I found out through a friend, and during his recent admission, he was able to get a palliative care consultant. We will have our first outpatient visit next week. Your talk was so informative. Thank you.
Well, firstly, you're welcome. Thanks for attending. I'm hopeful that this has been helpful for folks on the call. The oncologist role, I want to make sure I understand the question. Certainly, the oncologist role is in guiding recommendations for chemotherapy, immunotherapy, maybe referring that person over to other specialists, maybe to radiation oncology or to palliative care. Many oncologists, have more training in palliative care. Some may have more palliative care training than others. You're actually seeing a lot of trainees who are interested in oncology doing a palliative care fellowship and then doing an oncology fellowship because the skills gained in the training in our field can be really helpful. So you've got a lot, I think, of oncologists who feel more comfortable managing some of the medications I've talked about and managing some of the conditions that I've talked about. So without knowing the specifics, it's possible that that oncologist has been more or less managing that primarily. And some people definitely get referred over to us. What I would say, the advice I would give would be, if there's a thought and a desire to have an evaluation by a palliative care doctor, you should request it. That's surely within reason to request that. I've got a lot of patients who come to see me for a new patient visit, and we sit down and we take our time and we talk about everything. And fairly quickly we realize, well, you might not really need a whole lot of my expertise at this visit. You might, I might say, I think what your oncologist is doing right now, I fully agree with what your oncologist is doing and recommending for you. And I think that we're in a good place and I wouldn't make any changes. And I tell that person, yes, we're not making any, highbrow changes today, but now we're established together. Now we know each other. Now I'm part of your team and we're partnering together. So that if a month, 3 months, 6 months, whatever down the road, symptoms become more troublesome, we already know each other. I know what's been going on, and it's that much easier that we're already plugged in together to help more quickly. So my advice would be, if you're concerned, if you've got needs that you think would benefit from a palliative care consultation, simply ask. And I think most people are receptive to that conversation.
All right. Well, I think everyone got a lot out of today's meeting. Thank you so much, Dr. Murphy, for joining us. We do have some upcoming kidney cancer conversations. You can register for them on our website at jnfkidneycancer.org. And if you missed any part of this presentation, we'll be posting it on our website and social media by tomorrow. So thank you, everyone, and especially thank you, Doctor.
My pleasure. Thanks so much for having me. See you soon.
Have a good day, everyone.